Thanks. It's my pleasure to present the results of the study, which was one of the signature trials from our Stand Up to Cancer Research Institute immunotherapy dream team, and was co-PI'd by Patrick Ford at Johns Hopkins and Jamie Chaft at Memorial Sloan Kettering. These are my disclosures. Every day, thousands of patients around the world will get operated on for so-called operable or resectable cancer and will be told by their surgeons, "We got it all." Unfortunately, that frequently is not the case. If one looks at resectable lung cancer and looks at 5-year survival as a function of stage, this is the group that would get operated on. If you look in toto, probably somewhat less than 50% will have survived 5 years. So there is indeed a great need for additional therapies to be applied in the context of the surgically resectable setting. You've heard about wonderful results from immunotherapies in the stage 4 metastatic unresectable setting, but this is also an important area of unmet need. For these reasons, perioperative chemotherapy is recommended for resectable stage 1B through 3B lung cancer, but unfortunately, that ends up adding relatively little. Normally, neoadjuvant chemotherapy has been thought of as being given before surgery to reduce the tumor size to allow the surgery to be technically easier for the resection. But the scientific rationale for this particular trial of neoadjuvant anti-PD-1 nivolumab prior to surgical resection is shown here. The notion is that these tumors already have tumor-specific T cells sitting in the tumor, but they're restrained from being able to act by the engagement of PD-1 by PD-L1 in the tumor. One blocks that pathway with an antibody, and that results in initially an increase in activation of these cells within the tumor, but then the notion is that they will, or a portion of them, hopefully will spill out of the tumor, go into the blood, circulate through the body, and find those residual few cells that have gotten out and intercept those cells from returning and creating the relapse that ultimately kills patients who have had their primary tumor resected. So that was the hypothesis that we tested. This was the design of the trial. The goal was to achieve 20 patients, a small trial in which their tumor was completely resectable. 22 patients were entered on the trial with newly diagnosed resectable cancer. One turned out to be a small cell cancer, so was taken off the trial. 21 patients with non-small cell cancer went to surgery. One patient was non-resectable due to tracheal invasion, and so 20 patients were indeed fully resected, followed by standard of care. The objectives were safety and feasibility, and the exploratory endpoints were pathologic and immune responses and correlations to total number of mutations in the tumor. This was quite feasible. I'll simply say that there were no delays in surgery in patients, in all the patients that received pre-surgical nivolumab. These are examples of 2 of the 21 patients that had a radiographic decrease in their tumor. But the reality is that the majority of those patients radiographically were stable over the 4 weeks between the initiation of nivolumab and surgery. The question is, does radiology tell the story? What's actually going on in the tumor? We can, of course, answer that because the tumors are resected. And in fact, to our surprise, a much larger number of tumors showed significant pathologic regressions as defined by replacement of tumor cells by non-tumor cells. In this particular case, the major infiltrating cells that replaced tumor cells were in fact immune cells, mostly lymphocytes. 9 of 20 patients, or 45% of the patients on this trial, achieved a major pathologic response defined as less than 10% of the viable cells in the tumor were actually cancer cells. And in fact, 3 of those patients were pathologic complete responses in their primary tumor, which means that there was no evidence of viable cancer in the tumor just 4 weeks after they were given 1 of 2 doses of nivolumab. Now, we've seen then that in a lot of patients, the tumors are infiltrated with lymphocytes, but are there actual tumor-specific T cells that then leave the tumor and actually circulate systemically? So in my presentation later this afternoon, I'll go into this in more detail, but this is an example to show. These are 7 tumor-specific T cell clones that we were able to follow by a relatively new genomics approach called TCR-seq. And what you can see is that 4 of the 7 clones, which were barely detectable at the time of initiation of nivolumab, day minus 28, 4 of them shot up in the peripheral blood. Actually, 5 of them shot up in the peripheral blood within 2 weeks after the first dose, and the remainder shot up 2 weeks after the second dose, and even 44 days after surgery, they remain in the peripheral blood. This is the survival outcome. This is, of course, a small study. All of the patients have been now followed for more than a year post-surgery, and a number of them, as you can see, have actually been followed beyond 2 years. To date, post-surgery, among the resectable patients, there have only been 2 deaths. One of those deaths was unfortunately from a traumatic fall unrelated to cancer or therapy. So there's been only 1 death to date from recurrent cancer in this particular trial. Again, early and preliminary, but certainly very encouraging. So in conclusion, preoperative nivolumab did not delay surgery in any of these patients. 45% of resected tumors demonstrated a major pathologic response with robust infiltration of T cells. Not shown here, but I'll show this afternoon, reminiscent of Matt Hellman's presentation in metastatic cancer. The pathologic response did correlate with mutational burden. There was evidence for enhancement of systemic anti-tumor immunity, which is what we really wanted to achieve to intercept the outgrowth of distant metastatic cells. Clinical follow-up is encouraging, but larger trials are necessary. Currently, my estimates are that there are roughly 75 neoadjuvant PD-1 blockade trials that have been launched in 7 cancer types within the last year since the initial presentation of preliminary data from this trial. Again, to acknowledge the Stand Up to Cancer, Cancer Research Institute Immunotherapy Translational Dream Team grant, as well as grants from Longevity, LCFA, IASLC, and the Bloomberg Foundation, Sloan Kettering, Bristol Myers Squibb for providing nivolumab, and very importantly to our patients and research staff and collaborators in their laboratories. Thank you.